Okay.
Forward, let me just introduce Dr. Chen. Turns out that Reuben is a prestigious graduate of our medical school here at UC Irvine. He did a residency at the University of Minnesota in physical medicine rehabilitation. Tell me if I have this wrong. You established or started the Sun Living Health and Wellness Center up in.
Yep. Yeah. So here, let me give you a little background of myself. So, I graduated from UCI School of Medicine in 2007. I'm board certified in physical medicine and rehabilitation, which is a really long word for I do pain and sports medicine. I'm telling you, we're trying to change the name of our specialty because nobody understands it. I'm also certified in acupuncture. I am the Vice President of Business Development at Sunrider International, which is an herbal health food company. I also practice at Pacific Pain and Wellness in Torrance at a comprehensive pain clinic. Most of the patients that I see are pain focused. Usually hips, knees, shoulders, back pain, shoulder pain. I do some finger pain too. That's uncomfortable. I also do some cosmetic because I didn't ever imagine myself doing that, but it just happened. So, all right. So I'm talking today about PRP and stem cell. Let me give you a little bit of background, sort of what that is. So PRP and stem cell, it's broadly categorized when we are talking about pain management, especially when things like ligament injury, we're talking about something called prolotherapies. Very, very large, very broad term. It's been around for a while. Prolotherapy is an injection-based treatment. And the treatment is designed to stimulate local healing mechanisms. It's very, very general. Thousands of physicians today practice a type of prolotherapy. So prolotherapy actually was used between 1835 and 1935. Originally, it was used for hernia surgeries. What they would do is inject a solution to cause scar tissue formation to keep hernias from happening. Dr. George Hackett, who was a general surgeon, who was a hernia surgeon at the time, and he started to use, what he noticed is that when he did the hernia surgeries using prolotherapy solutions, that ligaments would also become thickened. And so he surmised that you could inject similar solutions into joints and tendons to also get a similar effect. And so he formalized what is today known as prolotherapy. In certain texts, there's also, you can get specialties in this, and the text was published in 1956. At the time, the solutions they used were what is known as a hypertonic dextrose, or a very, very concentrated sugar solution. They used something called the phenol glycerin glucose, or P2G. Basically, is these three, all of these are just irritant solutions. The idea is it just stimulates localized healing there. And then they use sodium lauroate. They've even used pumice or sand injected into joints to stimulate healing. That is inadvisable, but some people, but it was used at the time. So obviously, because these are irritant solutions, there are some side effects. One of the side effects, obviously, it hurts, and sometimes hurts a lot. And there's a side effect, obviously, of a lot of pain. There's swelling, but it's used to treat ligament laxity. Some people, because these are some of them more natural solutions, they do have some side effects like allergies to them. So that's something that was an issue for a time, and so today we have platelet-rich plasma, which is probably the most popular version of prolotherapy today. So you know, it's not something that just happened to start with Kobe Bryant and Tiger Woods using prolotherapy and PRP. This has gone back for a while. In the 1970s, they started to use what's called autologous blood products, or basically your own body to help wounds to heal. Part of my specialty is based in burn therapy. And it's very common for us to use a matrix mixed with somebody's own blood to help set skin grafts and for blood healing. So these type of products have been around for a long time, and PRP came about by concentrating the plasma or the potent healing factors in the blood, and what they created was something called PRP. In the 1990s, they started to use it a lot for dental procedures. They also use it a lot for cosmetic because PRP has an amazing affinity for adipose or fat, and when it's injected into the face, it does help with increased blood flow into the skin, and so it helps with decreasing aging, also helps with some reversal signs of wrinkling. Also, skin grafts were a very, very large part of PRP. Around the 2000s, a lot of orthopedic surgeons started to use PRP to help with bone grafts. One of the most notable ones in 2006, in the American Journal of Sports Medicine, the elbow and the Achilles tendons are the most studied areas of the body when you're talking about PRP. And this is one of the first studies that showed positive outcome with PRP. Basically, it was for elbow tendinosis, and they noticed a 93% reduction in pain after 2 years of follow-up. So following these, some of these good results, a lot of athletes started to get on board. I was privileged to have some opportunity with the U.S. Downhill ski team. They received on their off season a lot of PRP injections for their knees because obviously when you hit the moguls, your knees just turn into mush. So a lot of professional athletes. You recognize some of these names, these professional athletes that use PRP. Also, their endorsements with the National Football League, National Basketball, NBA, MLB, also World Anti-Doping Agency. So these are products that are frequently used specifically for pain management. So specifically, what PRP is used for is a non-surgical way to manage ligament and tendon injuries. It's not meant to be cure-all. It's not meant to literally replace a joint, but it can help maybe set back when you have to have a joint replacement or reverse some of the effects of long-term arthritis. So knee osteoarthritis, degenerative knee cartilage, elbow tendinosis, different muscle strains and tears. It's frequently used for rotator cuff injuries, jumper's knees, plantar fasciitis, which is quite uncomfortable, but it does work. And I mentioned before, rotator cuff tendinopathy. So I'll give a little background, sort of how it works. We'll go through it quick because I know that this is obviously the most fun part for a lot of people. But real quick, the platelets, they have granules inside of them. And the granules have different types of healing factors. When the granules are activated, fibroblasts, focal growth factors, they stimulate tissue proliferation, also stimulate blood formation and cell replication. Blood vessel formation is really important, especially when you're talking about tendon or ligament injuries, because usually there's just not a lot of blood flow depending on what kind of injury you have. And so increased blood flow, increased blood vessel formation is very important for healing. Also, platelets stimulate a number of cells to help with the healing process. You have macrophages. Some stem cells are also activated to help with the repair process. The little basic, any needle, stick yourself with a toothpick or whatever, it does promote local healing factors as well. So this is a lot with like acupuncture, it has a lot to do with this as well, has this background, but if you have increased concentration of platelets in the area and live platelets, the healing rates do improve. So here is, actually I wanted to go back and use more recent articles. So this one is published in Lancet in February 2015. And this is one of the first human in vivo trials to evaluate the immunohistochemistry of PRP on the tendons. What that means is most of the trials of PRP are usually done on animals, or they're done in vitro or not on living tissue. So this is one of the first that they wanted to measure the changes of the local chemistry in an injection in the Achilles tendon. So they had 20 patients.
one with ruptured Achilles tendons, 10 receiving PRP, 10 receiving a placebo. In the PRP, they noticed enhanced maturity of the collagen 1 deposition, as well as increased cellularity and glycosaminoglycans compared to the control. Basically, it literally showed what a lot of people had assumed: healing factors, local healing factors increased around the tendons, and collagen formation increased around the tendons. Now, the limitation of this study was a very short study. It was only over 6 weeks, but you can already see if the study was longer, they probably will have more information there. So really quick, what PRP, the whole process, if somebody has a PRP treatment, we collect between 30 to 60 cc's of blood, depending on what kind of area we're going to treat. And there are a lot of different kits out there that help to concentrate and separate the platelets or the platelet-rich part from the rest of the blood. These PRP kits usually involve a centrifuge, which literally concentrates all the platelets into a section. So I'll give you an example. 30 milliliters of blood will probably create between 4 to 5 milliliters of useful PRP solution. So you do need quite a bit to, and most joint injections are usually between 4 to 6 milliliters of fluid. So there are weaknesses, of course. There is not necessarily a standardized protocol for PRP solutions and PRP injections. Every kit that a physician uses may be a little bit different. So it's important in any search for somebody doing PRP to know the background, maybe know what kind of equipment that they're using, because that's very important. When I did training for PRP, we made our own PRP by ourselves. Literally, we'd have a couple of test tubes, we'd spin it, and we'd sort of do our little jerry rigging and separate out the PRP. Now, there's FDA-approved devices out there, much more sophisticated and much less risk for contamination. There are also PRP courses out there, but most physicians, these are based off of what we learned during residency with normal joint and tendon injections, so you don't really need anything that specialized. Blind injection is very common. What that is I just jab you in a place that hurts, and I hope that it gets to the right place. But that's literally what it is blind injection. And I trained in this, and it's very common. But there's a lot more new technologies out there, especially for large joints like hips and shoulders. So ultrasound has been used. I was upstairs and I was showing how to use an ultrasound device. But we use that to help with localization. You can also use X-ray guidance as well to help and make sure that the needle is exactly in the right place. And here's an example of an injection. And that bright thing there, that is the needle going into the area. So that way you can visibly see where it's going. So the treatment protocol is typically, most PRPs, injections are either done in single or in series. This does depend on the severity of the injury. People with more mild cases, more mild injuries, obviously will probably require less treatment. There is a trend now with research going towards less injections. So a lot of doctors before, they give you 4 injections once a week, but nowadays you probably decrease that maybe to just a couple over a period of time. Patients should experience some soreness and some swelling because the healing factors do cause local inflammation. But usually between 2 weeks to 2 months following the procedure, there is, most people will experience a change. My experience has been at least 20% improvement, and that continues for maybe up to 6 months to a year following the treatment. So there is an aspect of patience that's needed because the body does take some time to heal itself. Every person's healing ability is a little bit different. Teenagers, athletes typically heal much quicker than, say, somebody in their 70s, and so that needs to be taken into account. Optimum platelet count usually is between 1 to 1.5 platelets per microliter. That's just a technical thing. Basically, how much they concentrated, and that's why it's important to know what kind of equipment you're using. Now, there are some contraindications. Now, this, because it does cause a localized inflammation, you can't take any anti-inflammatory. So if people are taking steroids at the time of, or they're taking aspirin or ibuprofen at the time of the injection, it does counteract the effects. There's some controversy about whether or not Coumadin and Plavix would interact with the PRP, but most doctors who are doing the injection, since it is, majority of it is a cash-based, they'll just advise people to see if they can stop it for a short period of time. But any kind of immune modulating medication can affect it, so it's important people when they use it to not be taking it. Obviously, there's bleeding because you do have injections, maybe pain flares. There's risk for nerve damage or pneumothorax. These are common for any kind of injection, nothing specific for PRP. Something of note, it is not covered by insurance, so this is a cash-based treatment. A lot of it, just like the gentleman ahead said, that a lot of this is experimental, it is new. And so it is not covered by insurance, but most physicians usually have a deal or a plan for people so that it's affordable. Also, of note, it's autologous. It is your own body. So the risk for a reaction to your body, an adverse reaction like an allergic reaction, is extremely rare. So if somebody has a bad reaction to a medication, most likely there isn't that effect with PRP. There's a lot of research that shows that PRP in the clinical setting, there's positive benefits. A couple of research articles out there. This one shows that PRP did better than hyaluronic acid at 6 months after their injections for moderate arthritis. It's used in rotator cuff injuries. PRP was used in this American Journal of Sports Medicine article, showed lower re-tear rates after usage of, during surgery, they used PRP, and there is a lower re-tear rate for people who use PRP during surgery. Tennis elbow, they compared this to treatment with steroid, and initially there was improvement. Improvement was very fast, but in the long run, PRP group at 26 weeks had better pain outcomes. The next advancement, talking about before, stem cell, and with prolotherapy and therapy, and we talked quickly about fetal and stem cells and adult stem cells. Autologous stem cells, again, this is part of my practice, but autologous stem cells are part of your own body, so you don't need to worry about the risk. And they are, for the joint injuries, we focus on mesenchymal stem cells because these differentiate into muscle, cartilage, bone, fat, and nerve. So the most common type right now is either adipose-derived or bone marrow-derived. Bone marrow-derived was probably one of the first versions of stem cell therapy. It was used successfully for treatments of things like fractures, osteonecrosis of the hip, also decreased incidence for limb amputation. But right now, the biggest thing is adipose stem cell. It's a lot frequently combined with PRP, used for cosmetic treatments, and nobody seems to ever complain about taking a little bit of fat away to help with their pain. So that's a bonus. Probably the most common question I ask is, can you take a little bit more? So we only take a little bit, though. These type of procedures are usually same day. You don't need to culture your adipose tissue, but it has to be processed to help concentrate the mesenchymal cells. Again, the same contraindications. You can't take any anti-inflammatories. Usually the results come a little bit slower, but people do see improvement for over 2 years. So the improvement does continue for a longer period of time. Knee arthritis, hip arthritis are probably the most common ones that I see, but it can be used for anything. We've actually had injections for PRP and stem cell into the spine to help with disc injuries. So PRP stem cells used to treat lots of chronic musculoskeletal pain. It's part of the new field of regenerative medicine. It's great. There's lots of research behind it. It's not magic. It can't do everything, but there's a lot of promise behind this type of therapy, and there's lots of new research being brought to the field. Thank you very much, and I'm sure we'll have questions in a little bit.
Reuben, do you want to take some questions now?
Sure. Does anybody have any questions for me?
I have a quick question.
Sure.
A friend of mine just have steroid injection for her joint pain and all this stuff. She said it only lasts for 2 days. Will you recommend a candidate like this using PRP? Steroid doesn't work.
It sort of does depend on what kind of, what it was for. I mean, there could be a reason why the steroid injection didn't work. It may not be the source of her pain, so I would probably reevaluate the diagnosis just to be on the safe side. Typically, if a steroid injection works, PRP will probably work as well. If it doesn't work, I may look and see exactly the source of it.
Yes. MRI and
So I would probably look at the cause just to see that.
What's it cost to do that, stem cell?
So stem cell therapy, and so one of the, since it is cash-based, a lot of patients who shop around, what I've seen is that PRP probably can range anywhere between $350 to $700, depending on the kind of injection. If somebody does a spinal injection, usually it will be a little bit more because it will require like fluoroscopic guidance and X-ray. For stem cell, because it does take more time, there's this minor surgery involved, it usually is, depending on the type of injection, anywhere between $2,000 to $5,000, depending on the kind of treatment. But it's an option for people if they are thinking, if they're concerned about needing to have a joint surgery. Obviously, age does play a role, and the severity of the arthritis does play a role as well. Usually, moderate OA or arthritis seems to be better than very, very severe, but it's sort of a case by case, and it's something that people usually should discuss with their physician, making sure it's the right thing.
So far it's all cash based?
Yeah, it's all cash based. I know that there is a push for some physicians to see if Medicare can cover part of it. I've been looking into it. There has been some talk that it may become like placental stem cells, maybe, I don't know, maybe able to be covered by some insurance. That might be something in the future. So that's something that people are seriously looking into.
In the CPT coding for umbilical cord, there is a reimbursement system in place, and that is reimbursed actually to the hospitals or the clinics.
Yeah.
Is the worst that can happen, it just doesn't work? Or are there more negative things that could occur?
Yeah, that's probably the worst. I mean, there's always a risk involved with the needle, but it wouldn't be any more of a risk than a steroid injection. So that's probably whatever. If you had had a steroid injection before, the risk is probably not higher than that. And the highest risk is it just didn't work very well for you. That's it.
Is it FDA approved, and do you have any statistics on how many people has it, what % of people has it worked on?
Oh, that's a good question. So there's a lot of research out there. So when you do purchase, go to have a treatment with somebody, you do need to know if they're using an FDA-approved device. There are some devices out there that do use PRP and stem cell, but not all of them are FDA-approved. So that's a concern. But the treatment is FDA-approved by itself. Do you have any additional to go with that at all? Or?
But there's, as far as FDA is concerned, it's sort of is a gray area.
Yeah.
Again, as far as the manipulation or minimal manipulation, FDA is concerned about how you manipulate this plasma or PRP or the cells before you go in there. So there is a constant discussion between the industry and FDA as far as what is minimal manipulation, what is all entails. And FDA has basically sent a QA to all of us to basically discuss to see where this all lands. And there is a really, we are in that transition. We are constantly in talk with FDA as far as what they allow and what they do not allow. I think this has become sort of a standard of care that the FDA may basically reverse or adjust their current standing, but there is really no clear or concise direction from FDA with PRP or any of these stem cell therapies. Now, in our side, because umbilical cord and cord blood stem cell falls under tissue or tissue bank licenses, so FDA does not monitor that aspect of it. If you have cadaver skin or you have an organ transplantation, that happens basically under the tissue bank license and separates it from this basically service or minimal manipulation. So anyways, that's a long discussion, but I hope I did not confuse you, and that was not my intention.
But what about the statistics?
So the success rate of
Yeah.
it does depend on where and what you're treating. So
What about for knees?
for knees, and that also depends on the severity. So there's a lot of research out there right now for moderate arthritis for knees, and it seems more successful than the current things like hyaluronic acid. It's more successful than that. More severe arthritis, it does depend on the age and the viability of the tissue that we're injecting. Because if it's a much older, say somebody who's, the difference between the stem cells of somebody who's 85 versus 55 can be a lot. And the viability and the regenerative rates can be a lot different. So that's something to be taken into account. But say if it was a person in their 40s with knee pain, it would probably be good, depending on what kind of knee pain they had, it would be something to look into for sure.
I have two questions. You said it can be used for paper cup. If there is calcium deposit on the paper cup, this can help with
So this type of injection is mostly soft tissue. Anything like calcification or bone spur, it's probably something you have to refer to your orthopedic surgeon to have that removed. This one really works for you.
And also for like the knees, like soccer players, how long is it going to take to heal, recover, to go back and play?
Well, typically for most of our athletes, I don't really like them to take off any more than a couple days after the injection. The main side effect is right after the injection for a few days and they feel some soreness, but usually they go back to play really quick. And it should be included with some physical therapy at the same time and monitored by a physician, but usually its return to play is pretty quick.
Sorry, one more question. It can be used for ankle too?
Yeah, so Achilles, especially for like an Achilles injury, the Achilles tendon tears actually are quite successful. It's one of the most researched areas for PRP.
So along with the Achilles tendon tear, what about other tendons in the foot? Has that been just as successful?
The most researched is Achilles tendon because it is a very big fat tendon and it's really easy for people to take pictures of that. But I've seen people do injections for different other ligaments, including foot ligaments, hand, thumb ligaments, wrist, and it does depend on what kind of injury and how it's being injected. If it's using ultrasound to make sure you're on top of the tendon, usually it's been pretty good. Localized tendons is very good. If it's just generalized, I've got pain everywhere, then it can be.
So let's say if the tendon was torn away from the bone,
So torn away from the bone, it's my experience has been if it's completely torn away, then that's something you have to talk with your surgeon about.
Right.
Because you have to have it has to have a scaffolding for it to be able to repair onto. If it's completely torn away, say you have like a complete tear of your rotator cuff, and we'll be able to reverse that.
But a partial
Partial tear, yeah.
Then you'll be good to go.
It would definitely improve it a lot, yeah.
So, Reuben, obviously diabetes is a huge concern in our society, and oftentimes they have tendinopathies. So do you have any individuals that come to you for treatment for that?
Yeah, so this is usually what people, especially with diabetes, because they have difficulty with steroid injections because of the blood sugar spike that they get. And especially in maybe extremities that have poor circulation, this can help a lot with increased circulation as well.
So if you get 1 to 2 years using either the PRP or the stem cell improvement, and it goes up, you have the ultimate, what happens after that? Do you have to get it redone?
So that's a good question, and I get asked this question a lot, is after it heals, let's say you get the maximum healing on it, do you need to have the injection again? And usually I state is if you are continuing to do the activity that caused the injury in the first place, most likely. If you are, so I'll give the example of the downhill ski team. They would come in on the off season in the summer, and their knees are literally bone on bone almost. And we do the injections, and after they're off season for a couple months, they get much better. But then they go skiing again for an entire season, and so their knees come back, and their knees are, and they come back frequently for those injections. So, but if you have arthritis and we do injections and you don't, and you're just daily activity, maybe walking or bike riding or something, that shouldn't be a big issue. But yeah, athletes, you have to monitor.